Welcome to Connecticut eHealth Podcast, educating, conversing, and connecting for better health. The Connecticut eHealth Podcast is a space where we get together with local and national experts, key stakeholders, and other individuals in the space of eHealth to discuss health information in Connecticut and around the country. This podcast is brought to you from the UConn Health Interoperability, Innovation, and Learning Lab, where our mission is to promote the optimal adoption and use of eHealth by providing education and engaging in conversation with leaders to create connections for better health. So let's sit back and get connected. Hello, this is Tom Agresta. I'm a family physician and a clinical informaticist at the University of Connecticut, and I'll be your host for this episode of Connecticut's eHealth Podcast. Today's guest is Dr. David Henderson. He's the chair of the Department of Family Medicine and the Associate Dean of Multicultural Affairs at UConn Health. He received a bachelor's degree in psychology from Amherst College and a medical degree from Southern Illinois University School of Medicine. He completed a family medicine residency right here at UConn Health and joined its faculty in 2003. Dr. Henderson has been involved in the use of EHRs as teaching tool for our next generation of clinicians and also helping to foster public policy and approaches to improving health disparities. Thank you for joining us, Dave. It's a pleasure to have you on the show.
Well, thank you very much, Tom. It's actually great to be here.
And just as some background, Dave and I have known each other for the entire time and a little bit before he was a UConn Health faculty member. And it's part of the reason that I really wanted to have him share some of his thoughts and insights is going back to that time before that. So Dave, can you kind of give us a little bit of background on yourself and how you came to a career in family medicine and a little bit more also about what your role as the Associate Dean of Multicultural Affairs entails?
Sure, Tom. Thank you. I decided I wanted to be a family doctor because it was clear to me that family medicine was by far the most efficient way to practice primary care. And I was very motivated to do primary care. And I think that there are a lot of reasons we do what we do. But again, I think if we think of medicine as a service profession, I think the role of primary care doctors is really sort of pivotal in meeting that mission. And my role as Associate Dean for Multicultural and Community Affairs, I think sort of is linked to the reason that I wanted to be a primary care doctor, which is that it's about creating learning environments that are conducive to the success of all the learners in those environments, so that we bring students to medical school and we provide them what they individually and collectively need to be successful so that they can enter the workforce to provide high quality care to patients. And so in my mind, my role as a primary care doctor and my associate dean role are derived from the same motivation.
So Dave, in your role as department chair, you oversee the residency site for family medicine at UConn Health. And can you describe a little bit the characteristics of that and some of the importance of knowing our patients' unique social determinants of their health that we hope to improve?
Well, yes, I think in many ways, social determinants are the major drivers of health outcomes. There's, I think, a considerable amount of data that suggests that the clinical care that we provide actually only sort of accounts for 10 to 25% of the impact that results in specific patient outcomes. And a good deal of impact comes from social determinants. And I think that's reflected by the finding that the most reliable predictor of health outcomes is someone's zip code. And that speaks specifically to structural social determinants, as opposed to things that are more midstream, like behavior, which for a long time we had attributed a lot of health outcomes to. But there are a lot of structural issues that drive health outcomes. And I think being cognizant of those and finding ways to integrate issues related to social determinants into the regular care of patients is really important in improving patient outcomes.
And our residency practice site, being in inner city Hartford, certainly sees that as a reality in its day-to-day, patient care delivery.
Most definitely.
Yeah, and so Dave, You have been a real proponent of incorporating technology into primary care, and I've known that for a while about you. Can you explain a little bit to our audience when you sort of came to that conclusion and a little bit about the activities that you've done along the way to incorporate technology into clinical care and into teaching?
Well, I mean, I think for me, my sort of big epiphany on the road to Damascus, just to use that frame, occurred in at Jiffy Lube many, many years ago. It was like in mid 1990s, maybe a little bit earlier than that. And I just brought my car in to have an oil change, and the mechanic there actually brought up more information about me and my car in less than a minute than I could ever hope to bring up in my office with paper charts. Because I mean, half the time the chart wasn't in the chart rack where it was supposed to be. And again, it was a real eye opener for me that particular day. And why that particular day, I don't know. But I was just amazed at how much information he could access and how quickly. And this is my car. This isn't a sick patient. And so I was actually ashamed, because I immediately recognized that we should do much, much better in patient care. And it wasn't that I was so much sort of interested in technology, but it was clearly demonstrated that technology was a means of moving forward, and that in medicine, we were like way, way, way behind the curve. And so that was my initial sort of impetus or epiphany that got me on the road to having interest in EHRs, and actually ultimately working with someone who was then the CIO at the hospital that I was affiliated with, to produce an EHR for the practice I was in, because we couldn't afford any of the systems that were on the market then. They were far too expensive for our practice. So he and I built one for our practice.
And then I know that over the years, you've been involved in a number of other sort of utilizations of technology, both in teaching and in practice. Can you kind of walk us through how you see technology having changed, family medicine in that time frame?
Sure. I mean, I think that it has, I mean, the sort of evolution, sort of going from electronic health records and the capacity that has provided to manage patient information better, has allowed us to provide better care to patients. And I think in many ways provided much more efficiently and actually much more safely. I mean, I think the recent COVID, I should say the current COVID pandemic and the lockdown that drove us all in the direction of telehealth has been another sort of minor revolution, to the extent that we have managed to figure out how to provide a good deal of care to patients, and actually high quality care in the absence of sort of being physically present at the same time in a room with a patient. And I think that's something that is likely to remain a significant part of the landscape, because it is convenient when the sort of necessary resources are present. And even issues such as remote monitoring, which I don't think have sort of really taken hold, but something like remote monitoring, I think provides the possibility to extend care outside the office into patients' homes in really meaningful ways that actually can help give them some control over the issues that they deal with on a day-to-day basis, and all the while facilitating sort of communication between physician and patient.
So you've kind of raised some really interesting sort of, some of them very rapid changes as the adoption of telehealth, and some of them much more, slow changes, and some futuristic ones such as remote monitoring. Can you talk a little bit about, your knowledge of underserved populations, and the maybe some of the opportunities you see, but also some of the challenges you see in utilizing technology to better outcomes for their health?
Thanks. I mean, I think, well, underserved populations are particularly challenged. And again, the challenges are often structural, and trying to come up with ways to overcome those challenges can be daunting. We often talk about food deserts, but with the degree of racial and ethnic segregation that exists in this country, there are a lot of communities that are just sort of cut off from access to things that many of us take for granted. And I think technology can provide means for reaching those patients in ways that are meaningful and helping address healthcare issues, and also empowering people from some of those communities to give them more agency in their own care and ultimately outcomes. So, I think with the correct inputs, technology can be used very effectively to address or at least to ameliorate the impact of a lot of structural social determinants.
So I certainly agree. And I think that there are both opportunities and some challenges there. One of the areas that I know at the state level that is really important to a lot of individuals really has to do with sort of better understanding and connecting individuals in need with the services that they could benefit from. And I know that as the social determinants of health are increasingly coming into focus, that there are data points and information that needs to be gathered that allow us to effectively track and improve stuff. So if you were to tell us what types of things should be collected to improve those health outcomes, what kinds of things would you suggest?
Well, if I understand your question correctly, I think that one piece of it is actually sharing information, because even at the sort of current level, sort of high level of penetration of electronic health records, data is still fairly fragmented. And so the primary care office, like Asylum Hill, may have its data set on a given patient. Their cardiologist may have some different information. Certainly, if anybody is outside a given health system, there is a lot of fragmentation of information. And on some level, we are still sort of playing, it's like the game of telephone, where someone provides some information and then it's sort of passed down the line from person to person. And by the time you get to the third or fourth telling of it, things have changed significantly. And the information isn't as accurate as it was, and doesn't as accurately reflect what was initially collected. So I think having interoperable systems will allow us to, I think, better manage information and better serve patients. On the patient side of this, I think, sort of broadband access is really key. There's really, at this point in our evolution, broadband access is sort of like a street light. It should be a public utility. And it's, I think, necessary to help remedy some of the isolation that occurs in some community, just sort of given the level of residential segregation that we have. And that access and the communication between sort of patient and provider could really, really, I think, improve the overall access to care that people experience, and thereby improve outcomes.
So Dave, those are really good points. And obviously, having equal access to data through the use of technology and equal access to communication back and forth between providers and patients is really critical. And, that will be one of the things that helps with improving social determinants of health. And also, I think the ability to sort of aggregate data through a common set of tools, such as maybe our state's health information exchange, may well be another way that we can improve things. As you may know, the state's HIE has a mandate to actually collect race, ethnicity, and language data about our patients, but that's probably not fully adequate to gather and understand things better. What additional data would you think that would need to be gathered to allow us to address things most effectively?
Well, I think that, again, if we think about the practice of primary care in general and family medicine in particular, I think on an ongoing basis, we collect a lot of information about social determinants. That information isn't always sort of organized in documentation in the most opportune ways. But I think as newer templates are being developed, that has changed and will continue to change. I mean, so I think that there is a lot of social determinants related data that is collected in offices, data like sources of income, stability of housing, issues related to food insecurity, basic personal safety, transportation. All of these things we actually discuss with our patients, and we make an effort to help them deal with the things that are impacting their day-to-day lives and generally subsequently their health. And I think structures like HIEs can be very useful in aggregating that data across the many places that patients sort of brush up against the healthcare system. And in that aggregation, provide a really sort of robust data set to look at things from a population level, but also provide the ability to drill down geographically into and look at specific communities and actually drill down onto specific patients to develop predictive models for adverse outcomes. Predictive models, there was a paper I read not too long ago about modeling HIE data to predict a patient's likelihood to end up in the ED in the next 12 months. And once identified, interventions can be engaged to provide support for that patient to prevent that outcome, and thereby provide better care to the patient and to decrease healthcare expenditures.
So those are excellent, ideas, Dave. And I think that you've, kind of outlined, how data that could be collected and aggregated and analyzed might actually benefit, populations of patients as well as individual patients. There also are other use cases that a health information exchange could undertake in order to improve outcomes for the healthcare of the underserved. And you touched on the idea of some of the data being gathered around food insecurity, financial challenges, et cetera. What kinds of tasks can an HIE potentially undertake, in your opinion, to improve some of those situations?
Well, again, I mean, it's a really rich data source. And the things that need to be done to improve patients' health are often things that fall outside of things that we write prescriptions for typically. And so as an example, in this office, we did a pilot of a program that I think was sort of a takeoff on the sort of food is medicine idea. And so in this case, housing it was medicine. And so people who had housing insecurity or who were homeless, I mean, we actually were able to provide housing vouchers to these people. And again, that's sort of one thing that is done in this office, and collecting that information from patients may be somewhat variable over time, but with a sort of large data set like an HIE, it is a lot easier to put together a reasonably comprehensive data set on, again, communities, but also potentially individual patients, so that we can make referrals for things like housing. We can make referrals for things like food assistance. We can make referrals for issues to help address transportation. And all of those things can contribute substantially to improving the health of individuals. And again, depending on where the input is, also potentially the health of populations.
So those are really important comments, Dave. And I do know that one of the goals for our state's HIE, Connie, is to actually set up the capacity to do electronic referrals through the HIE for such things as food banks, et cetera. So I think what you're describing there is not just the ability for the individual practitioner to do it, but utilize the state's HIE infrastructure to potentially actually do that electronically. So I really look forward to how that plays out over time. Why don't we take now just a moment to kind of hear from our sponsor, Connie, and learn a little bit more about them, and then return for some additional questions. We want to take this opportunity to thank Connie, Connecticut's official health information exchange. Connie was established in 2019 to oversee and provide services to support the exchange of health data in the state of Connecticut. Connie is an independent and not-for-profit organization. To learn more about Connie, please visit conniect.org or go to the show notes from today's episode. So returning from our break, Dave, I'd like to actually focus a little bit more on your role in an academic institution and your responsibility for oversight of training of our medical students and residents, and to have you focus a little bit on the principles and teachings that should be included in education around technology and how it could be used for healthcare access and outcomes.
Thanks. I think that informatics needs to be a sort of core element in curriculum these days. And that realization, I think, is being experienced by a number of folks in a number of medical schools. And so there are a lot of conversations about how best to incorporate informatics into medical school curricula. And the sort of curriculum is a finite space with a lot of things sort of packed in. But I think we do need to make space for informatics because it is a tool that is and certainly will be as effective as stethoscopes going forward. And so the landscape in which, say, we practice during the early parts of our careers will be very different than the landscape that current learners experience. And so I think informatics needs to have a central role in medical education because data analysis and management is really key to both population health and to individual health.
So that's a little bit of a topic that's near and dear to my heart, obviously, as a tried and true clinical informaticist. Can you talk a little bit about how technology's changed the way your learners are actually learning now and not necessarily just what they've got to do in the future, but how has it already changed things?
Oh, I mean, I can sort of talk about that sort of pre-pandemic and pandemic. I think the pre-pandemic version is that, and certainly sort of using UConn as an example, we switched to team-based learning, which from the regular sort of lecture mode of education. And team-based learning applies a flipped classroom model where students get information that they go over independently, and class time is spent discussing what they've learned on the outside, refining specific concepts and applying those concepts. And so the entirety of the curriculum is and has been for some time online, and that's how students engage it. The materials they use, the textbooks they use are all digital. Even anatomy, some of it is still cadaveric, but some of that is also digital as well. And so, I think technology already plays a huge role in the delivery of medical education, but central to what is provided students is the context of the patient. And so the patient is always front and center in their learning because everything that they're learning needs to be sort of applied to a patient. And so the use of technology hasn't pushed the focus of patients out of medical education, which I think is really important.
Yeah, certainly. I think anything we do needs to kind of be patient centric and not necessarily provider centric or technology centric. And as you know, that's been a sort of long-term mantra of mine, where I've kind of had the approach to my career is trying to promote high tech, high touch, provision of primary care and family medicine.
Yeah. And I was just going to add that, technology really saved us during the pandemic because, UConn, like just about every other medical school in the country, just switched to doing everything online. And so everybody was sitting in their living room or at the dining room table in class together on WebEx or Zoom or whatever platform a given school was using. And those transitions occurred really, really quickly, but they were very effective in maintaining the continuity of education. And in the absence of that technology, I mean, many schools would have closed for a year.
Yeah, I know even in
that's very disruptive.
absolutely. And I know even in my own clinical care and teaching activities that I was able to actually bring learners in and collaboratively have them work with me on telehealth encounters from a remote location, so that even if we weren't physically in the same location, protecting each other and protecting the patients, we were still able to kind of both care for the patients and learn at the same time. And so I think there's opportunities to incorporate those things kind of going forward as well. Much of it has kind of slowed down a little bit, I would say, as the pandemic has receded a little bit, which is good in many ways. Let's talk a little bit about what you would hope for future education opportunities for clinicians, and thinking a little bit about how you'd like to have them learn about the use of technology in clinical care.
I mean, for me, I mean, I think a great model for education and introducing technology into education is actually having a sort of curriculum built around an electronic health record, which and the use of real patient data. Because I think when we sort of create cases, I mean, we almost inevitably insert some of our biases into the structure and content of those cases. Using real patient data that's de-identified, I think, can be a very effective way of, again, maintaining context of and focus on the patient. And if the technology that they're using in clinical settings is the same technology that they are using in the classroom setting, and if that's the sort of portal for engagement of the curriculum, I think that creates a fairly seamless learning environment between the classroom environment and the clinical environment. So I think that is one element that we are likely to see take hold as we move forward. And there are different sort of preliminary examples of that in schools around the country, but I think that is likely to be a trend for the future, because again, it does become a way to combine sort of classroom teaching and clinical teaching into a sort of a common experience for students.
So those are great examples, and I'll kind of extend that a little bit and say, we know we're rolling out, a yet to be, kind of fully operational health information exchange, and that we want to actually have our learners understand, the potential uses of it and actually be capable of utilizing it in their own clinical environments, whether those learners are residents or students. Can you just sort of take what you're thinking, what you've kind of stated before, and apply that to teaching students how to use a tool that's in real use, and how to have them, kind of teach others how to use it? What would you do? How would you approach that?
Well, I mean, I think that if we're talking specifically about an HIE, I mean, I think that one of the things that we are emphasizing for students is the importance of population health and understanding sort of population, sort of individual health in the context of population health. And so having a tool like an HIE, which is a large data set of patient information, allows them to develop skills in extraction of data and data analysis that they can use specifically in the care of individual patients, and to understand the sort of elements that impact patients and lead to specific outcomes. And while they are sort of learning the physiology and pathophysiology of illness and disease, they're also learning some of the basics of public health and how individual and the health of populations intersect, and also learning how to create interventions at both levels, which are really important if we are going to improve the health of our nation. It'll occur community by community.
So those are great examples, Dave. What do you think, if you had a message to the leadership of the Health Information Exchange, what do you think they could do to support this process?
Well, I mean, I'm not sure. I don't know if I'm qualified to give them suggestions, but I mean, I think the suggestions that the main suggestion would be to think carefully about how to provide access to the HIE as a learning and teaching tool. Again, I mean, it has sort of real patient information, so sort of HIPAA and privacy is always a concern, but access to a data set like that would actually be really important. And I can provide a really concrete example, which is that in order to really sort of robustly complete one of the population health exercises that we provided students, we were fortunate enough to find a database in New York State that was large enough and organized in a way that allowed students to successfully complete the exercise. But at the time, there wasn't anything available here in Connecticut. So it would be wonderful if data sources like that were available in state.
So, Dave, that's a really good set of ideas. I also would add to that and say that students are assigned to clinicians and to clinician practices. And so right now, I'm not sure that it's anticipated that students would have access to the HIE data set, but perhaps if they're actually have a HIPAA relationship where they're working with a clinical provider, maybe they could actually be a partner with that clinician in utilizing the HIE to improve outcomes for the patient population that clinician is responsible for. So there might actually be more than just simply the data set and the learning from it. It might actually be to use the tool for their own clinical involvement with their preceptors.
I think that's a great idea. And again, would I think sort of blend the sort of classroom and practical clinical learning.
Yeah, and so also residents as well, making sure that residents have access. Dave, this has been an absolutely fascinating conversation. In closing, though, do you have any kind of words of wisdom for our listeners about sort of the major takeaway points that you'd like to leave them with?
I think that, I mean, technology can sometimes be a little daunting, and sometimes it can be somewhat intimidating. I think that technology is with us and it's here to stay. It's incumbent on us to find productive ways to put it to use for the betterment of ourselves individually and collectively. And I think that one really important thing, just from a social justice issue, is internet access, because access to information is pivotal presently and will continue to be. And the extent to which sort of some people have access and other people don't have access, I think creates an unequal society. And that inequality has definite impacts. And it is antithetical to the aspiration to social justice.
An excellent set of parting wisdom. And Dave, I'd really like to thank you for participating in our eHealth podcast, the Connecticut eHealth podcast today, and look forward to having additional conversations with you in the future.
Tom, thank you very much. It was great to have a chance to have this conversation. And it's always good to talk to you.
And you as well. As always, wishing you the best of health. Your host, Tom Agresta.